Good evening, friends. Welcome to all to this particular part of the training program. Today, we are going to talk about echocardiography and coronary disease, and for which we have with us Dr. Samir Srivastava from Fortis Escorts Hospital at New Delhi, Okla. All of you know about Dr. Samir Srivastava. Is ace cardiologist, absolutely brilliant knowledge of clinical, non-invasive, and multi-speciality of cardiology knowledge. Like you talk of a valve, you talk of a coronary disease, you talk of any subjects in cardiology, where he has got one of the best possible knowledge what we have. He's younger brother to me always, like we share many things together, and in all kind of a distress and positive situations, we are always there together. With this few words, let me hand over a mic to Dr. Samir. Is all yours.
Dr. Rakesh, you say good things about me only when Rashmi has left the room.
No, I'll come down one day and say everything to Rashmi in presence of you when nobody else is there then.
So, good evening to you all. And today is a topic which is actually bread and butter for all echocardiographers. Let me just tell you that if coronary artery disease was not to be there in the world, echocardiographers would have had maybe 20% of their practice left. So we have grown from the evaluation of heart disease or body disease for that matter by looking at the urine and then the pulse, and then over a period of time it was Lennig who discovered stethoscope, and now we are into phase of echocardiography. So these are the places where people have been using echocardiography for all times. We know that there is a short axis, we know there is a apical 4-chamber and 3-chamber views or 2-chamber views. We are going to talk about segmental wall motion analysis. Unfortunately, acute myocardial infarction till was to be diagnosed and treated based on only two things: history and ECG. Then came the era where serum biomarkers became existent, and then they started having their own roles to play. But actually 2018, echo had no role in treatment, diagnosis, or anything of acute myocardial infarction per se. The reason was very simple. It was not that it didn't have a space or it didn't deserve a space. And how was it divided? Just at the base, there were 6. And the place where there was a papillary muscle, this was the place which was the mid-level, and apex was where the papillary muscles just finished, or this was the 16 segments. Now, unfortunately, in imaging, cardiac imaging has got CT scanners, and they have got MRIs, and they have got nuclear scanners, myocardial perfusion imaging, and the PET scans. So these all people, they continue to use the 17 segment model. And that's the reason why the 17 segment model, this was the 16 segment model, where this was a short axis across the papillary muscles, where there was a septum which was divided into anterior septum and the posterior septum, then the inferior wall, the posterior wall, the lateral wall, and the anterior wall. This from base continued to be at a higher level into the mid segment, and apex had only 4. This continued to rule the roost till several decades. And then it was for a consensus of opinion between all the imaging modality, a 17th segment was introduced. And this 17th segment was the apex. Now, when you look at this apex, how do you define apex? The apex is defined that wherever the cavity finishes, provided it is not a foreshortened view. And how do you decide that it's not a foreshortened view? This is the place where the instead of having a peak, if it is obtunded or it is rounded, then that means you are not at the apex. And this is the segment which is the thinnest portion as against rest of the myocardium, and that is how you identify the apex. And this is the 17th segment. Now, why do you have to define these? Because it has some relevance. So we know that three arteries supply the heart. Actually, there are only two. One is on the left and one is on the right. The one on the left divides into two huge ones, that is the left anterior descending and the left circumflex. The right continues to give its own small branches, and thus we say that it is three arteries which supply the myocardium. Now, there is some relevance in defining the segmental wall motion because you can have some rough idea that which is the segment which is supplied with which coronary artery. So if it is the anterior septum or the anterior wall, then this is supplied by left anterior descending artery, which travels in between the interventricular groove. Then there is lateral wall or inferolateral. There's nothing like a posterior wall these days. What we used to call the posterior wall is now inferolateral wall. And this is supplied by circumflex, which travels in the atrioventricular groove. And then there is inferior and inferior septum, which is supplied by and large by RC. Now, there is a lot of overlap. There is a lot of overlap, and the worst is apex. Because if LADs also have three types, one is type 1, which stops short of apex. There is type 2 LAD, which goes till the apex. And there is type 3 LAD, which wraps around and goes backwards in the interventricular groove posteriorly. So if it is a type 1 LAD, that means apex will be supplied by something else. And most of the times it is posterior descending. Now, this posterior descending in a good about 17% people is originating from circumflex, and greater than 80% or so would be from the right coronary artery. So there is a lot of overlap, but most consistent is if you are seeing that anterior septum and anterior wall is gone, then you are pretty much sure that you are looking at the LAD territory. So this is the echo view for wall motion abnormality, and these are the left ventricular segmentation. The 6 at the base, this is a bullet. You have compressed the whole heart from top to bottom and made a bullseye. And in this bullseye, there are 6 segments. This is basal anterior. This is basal anteroseptal. This is basal inferoseptal. This is basal inferior. This is basal inferolateral. Like I said, there's nothing like a posterior wall these days. And this is basal anterolateral. Now, come to the top, higher floor, and you again have the same things here. And when it comes to the apical segments, then the 4 apical segments are apical anterior, apical septum, apical inferior, and apical lateral. And 17th is the apex segment. So this is your left ventricular segmentation, and universally, regardless of which imaging modality you use, these are the ones which are used. Now, this is the same depiction what I have done in a bull's eye. Here, if you look at this, this is the LAD territory. Most of the times, LAD is supplied by, apex is supplied by LAD. And then this is the circumflex territory. And here there is, so this is the segment which is supplied by posterior descending. Now, if the posterior segment descending is from the circumflex, then this will be colored like the way circumflex is done. These are again graphic representation. How does it look in real life in parasternal long axis? This is In parasternal long axis, this is anteroseptal wall. And this used to be the posterior wall, which we now call inferolateral. So inferolateral, in parasternal long axis, you see only anteroseptal wall and the mid anteroseptal wall, basal and mid. So you see basal and mid. If you start seeing the apical segments, that means you are not in true parasternal. A true parasternal should not be showing the apical segments. Cut across, rotate your transducer to 90 degrees, and you are in the basal segments of the left ventricle. And this basal segments can be divided into 6: anteroseptal, inferoseptal, inferior, inferolateral, anterolateral, and anterior. Go a little more towards the apex, fan it up towards the apex, you will find the basal level, and fan it up further towards the apex, you will find that there is an apical segment of anterior apical, septal apical, inferior apical, and lateral apical. Cross this and you are at the apex. This is how you see. Now, let's define wall motion defects. All of us have our own ideas about what wall motion defects are. But wall motions are dependent upon from baseline. And what is that baseline? Baseline is diastole. From baseline, whenever there is systole, how much is the thickness or contractility of the myocardium? If the myocardium thickens 1.5 times, this is a normal kinesia. If it is 1.2 to 1.5 times, it is hypokinesia. Less than 1.2 or less than 1.1, that means there is hardly any contractility. It is akinesia. Now, dyskinesia, all of us think is bulging, which may not be wrong, but if you look at the truest definition of dyskinesia, it is paradoxical thinning of myocardial on systole, which obviously is manifesting as bulging out of the myocardium. But when it comes to MCQ answers, the MCQ answer of dyskinesia is during systole, if there is thinness or thinning from the baseline of diastole, it is dyskinesia. And last is aneurysm. And what do you define aneurysm as? If there is this paradoxical thinning, which is persisting in diastole also, then it is aneurysm. If it is not persisting in diastole and occurs only in systole, then it is dyskinesia. If it is persisting in diastole and systole both, then it is aneurysm or a scar formation. Now, things are very clear. Except for scar, you can't comment on viability. If you are seeing a scar, that means the thinness is less than 0.5 millimeters. And if it is lesser than that, you are sure that it is non-viable. For rest, hypokinesia, akinesia, you cannot comment upon this because it can be viable, it could not be viable too. So some facts about regional wall motion abnormality. Regional wall motion abnormality, if it is present, then the chances of finding ischemia or myocardial infarction has a positive predictive value of only 50%. So this was one of the reasons why it never saw a utility in acute ischemia or acute myocardial infarction, because the positive predictive value was so little. However, if there is no regional wall motion abnormality, then these patients are unlikely to have an acute myocardial infarction with a negative predictive value of 95%. And this is what was debated, and that's the reason why it has now found its own space, because absence of wall motion abnormality means that there is hardly any myocardial infarction of significance. The enzymatic rise can be there, but of significance it is not there. Now there is something known as a wall motion score index, and if your wall motion score index is greater than 1.7, then the perfusion defects are greater than 20%, and are at an increased risk of further complications. There are a lot of problems with wall motion abnormality, but fortunately with the current generation of machines, this factor is hardly any, and uh, poor echo windows are, I'm sure Rakesh will agree with me on disagree with me, but poor echo window in the current circumstances with availability of contrast is hardly existing. There's nothing like a poor echo window for wall motion abnormality with availability of sonicated contrast material. Well, operator, you have to be a good operator, and this is usually the problem, obesity of this sort, that this is a difficult thing to image. These are the technical caveats in assessment of wall motion abnormality: obesity, thick chest wall, lung disease. Lung disease is still Achilles heel, but some of the most people who got lung disease will turn out to have some available windows, and several times which we don't explore is subcostal, and you'll find that because of the lung problem, you can get a very good subcostal windows. Now, echo in coronary artery disease and acute coronary syndrome is something which you have to pick it up early. If you look at the ischemic cascade, this was a dog model in which what they did was they tied the left anterior descending of the dog and started seeing what all things happen. So the first thing which happened was that there was lactic acidosis in coronary sinus. So acidosis in coronary sinus is the first thing which happens in ischemia. Next thing which happens is a diastolic dysfunction. Then what happens is perfusion problems, and then what happens is regional systolic dysfunction, then the ECG changes and chest pain. So, but for the lactic acidosis and perfusion, what you can pick up is diastolic dysfunction and regional systolic dysfunction rather early in the ischemic cascade than to wait for it. So this is yet another fact that about half the patients presenting to ER with chest pain and later having confirmed myocardial infarction have non-diagnostic ECGs. But fortunately, availability of high sensitive troponins, this thing has been sorted out by and large. About 3/4 of the patients with non-QMI, now these days it is called non-ST elevation MI, present with ST depression only, and 80% of these have subtotal coronary occlusion on angiography. So these are certain things which make us that we should be using echocardiography more liberally than what it is being used. When you did echo in acute coronary syndrome, and this was almost about 20 years back that this paper was published, 25 years back to be 1997, 23 years, that echo provided a new and useful information in 29% of patients admitted to CCU. It is twice more likely to be useful in those who had an echo in the recent past within 3 months. So it is, if you have somebody who's got a baseline echo within 3 months, then it is more predictive as compared to people who don't have this. So can it predict cardiac events in patients with chest pain? Yes, it can. If there is a person who this is a study when they had within 4 hours of chest pain they presented. And if there was somebody who had a wall motion abnormality and ejection fraction less than 40%, the data suggested that the sensitivity of predicting events was 91% based on echo versus ECG where the events was 40% or thereabout. Multivariate analysis showed that it was only male gender and positive echo which predicted cardiac events, and for women this was dubious. This was something which was suggested almost 3 decades back, that when you have ST segment evaluation, what you should do is do a triaging. If there is a ST segment which was there, then you admit, and this is for a triaging. If you don't have it, then do a 2D echo, but If it is technically adequate, wall motion abnormality, admit. If no wall motion abnormality, not admit if clinically stable. However, if there was global dysfunction or there was technical inadequacy, you admit or not admit based on the conventional criteria. So somewhere here, the troponins have figured in and have kind of diluted the need for triaging with echocardiography. For prognostication, yes, it has a reasonably good benefit. People who have got ejection fraction less than 40% have higher event rate for wall motion systolic, wall motion score index of greater than 1.7. They have that. This means that there is an extensive infarction. And like I said, that greater than 20% perfusion defect is found on myocardial perfusion imaging. Restrictive mitral valve inflow, which is tall E, short A, small IVRT. These are independent predictors of development of CHF and increased mortality. You can use this. It's very simple to do. Myocardial and mitral valve inflow pattern is very easy to do. NLE enlargement is something where people produced a lot of data and it is kind of forgotten, but we use it very, very extensively. I mean, LV dilatation in an acute coronary syndrome or a myocardial infarction is an independent risk factor for sudden cardiac death. The vitamin stress echo, ischemia of non-infarcted segments predicts multivessel coronary artery disease. Now, this is what I was trying to highlight, LV end systolic volume index. And it identifies patients who are at a higher risk of heart failure. And left ventricular end systolic volume is the lowest amount of blood in the ventricle at any point in cardiac cycle. Simple, but most powerful standalone marker of LV remodeling, most informative and load independent, most powerful predictor of survival and repeated hospitalization. Now, these are the normal values of end systolic volume index. If your end systolic volume index is greater than 43, then you are looking at a bad prognosis. Like the way there is an end systolic volume index, there is something known as an end diastolic volume index, where you calculate the volume in the diastole and divide it by meter square, and you get the height in meter square of a person, and you get a diastolic and diastolic volume. So roughly, if you want to remember it, the normal values for end systolic volume index is 50 and normal values for end diastolic volume index is 100. So multiply it by 2, and these are bad prognostic indicators. So acute MI provides quick bedside markers of ongoing ischemia, extent of jeopardized necrosis. However, resting echo overestimates the infarct size. And this is a very interesting thing. You have a wall motion which is involving, say, maybe 6 segments. Is it truly 6 segments that they have gone for a 6? No. Echo overestimates the size of infarct as compared to perfusion imaging and as compared to MRI and as compared to PET scan. Also CT scan. Now, why? Because lot of area could be stunned area, lot of area could be hibernating area, and lot of area will not be allowed to contract because the normal portions keep pulling it down. So this is something which is tethering, which can happen. And this is, if there is any confusion about stunning, hibernation, tethering, ischemia, I can pick it up when I finish this talk and we can have some discussion on this. Now, one major issue where echo comes as a very, very important tool in acute coronary syndrome is detection of complications of myocardial infarction. In acute phase, all you want to do is calculate the LV systolic dysfunction. But not only that, you have a free wall rupture, you have ventricular septal defects which can happen, papillary muscle rupture and subepicardial aneurysm. These are all mechanical complications of myocardial infarction which are best predicted or picked up by echocardiography. Not only that, you can pick up mitral regurgitation, LV dilatation, papillary muscle dysfunction, papillary muscle rupture, LV thrombus, pericardial effusion tamponade, RV infarction, LV outflow tract obstruction, all these things can be picked up very easily. Just to pick up a few examples from, if you look at this, this is an LV aneurysm, large dilated LV where there is hardly any contractility and the apex, and from this point onwards, you can see that it is a large. So LV aneurysm is sure short sign of non-viability. These are a few examples of cardiac rupture. If you look at this, this is a rupture which has happened here. This is a person who had an anterior wall infarction. If you look at this anterior wall, it is hardly moving here. And actually the rupture occurred at a place which is in the posterior wall, which is now called the inferior lateral wall. So why does it happen that an anterior wall infarction person ruptures in posterior wall? This is happening because this must have been a type 3 LAD. And when the LAD is wrapping around the whole of LV, then the rupture invariably and always occurs at the place where there is a junction of infarcted tissue and normal. Because the shearing forces are such that this shearing forces of infarcted and normal tissue become so gross that it gives way and the patient ruptures into the pericardial cavity. Here is yet another example where there is a person who has got acute mitral regurgitation, and these mitral regurgitations are a sign where if you can't stabilize them, these are patients who need to go for surgery. So all these three examples, this is again a parasternal long axis where there is a person who has had a ventricular septal defect or a ventricular septal rupture in the septum, and you can see left to right shunting. And these are the patients where the patient needs to go for surgery now. So these are three kind of very dramatic examples. One is cardiac rupture, another is mitral regurgitation, third is ventricular septal defect. These are three mechanical complications of myocardial infarction where the surgeon has to be involved now. Okay. Here is yet another example of now, this is very interesting. If you look at this picture, you find that there is an aneurysm at the septal base, which probably is going into the posterior wall too. But if you look at this, this is an aneurysm, and at the junction of the aneurysm and the normal, there is a ventricular septal rupture which has occurred. So this is yet another example of a VSR which is happening. But here there is a combination of an aneurysm, and the edge of the aneurysm has given way, that there is a... Okay, so this is yet another example of anybody. I would want to invite anybody to make a diagnosis here. And
LV thrombus is there.
Lovely.
Apical aneurysm with LV thrombus.
Aneurysm? Who said aneurysm?
Apical aneurysm.
Maninder?
LV thrombus is there, sir.
Dr. Vinay, so I said it's aneurysm with LV thrombus.
Okay, Vinay, anybody disagrees with him?
No, there is apical aneurysm.
Apical aneurysm, I am not denying it at all. Thrombus I am not denying, but any other, because this is a person who has to go for surgery now.
So can you repeat?
Anybody who disagrees with him?
He has got aneurysm.
Aneurysm?
Yeah.
Okay.
Free wall rupture.
Free wall rupture.
No.
Who else? Anybody else? Aneurysms don't need to go for surgery now, but I'm insisting that this man has to go for surgery now.
And there is a rupture.
So if you look at this picture alone, there is a neck which is a short neck. In the cavity, there is a ledge of tissue, and there is a thin, very thin covering, and there is a thrombus which is sitting inside.
Impending
Now,
rupture. Impending rupture.
impending rupture.
Because aneurysm is there. It's a very thin walled aneurysm.
So, is it an aneurysm or is it a pseudoaneurysm? And what is the difference between pseudoaneurysm and an
It is
aneurysm?
a pseudoaneurysm because the
It has a thick neck, wide neck.
Not thick, right?
Wide neck.
It's a very
wide
narrow
neck.
neck.
Wide neck.
It's a pseudoaneurysm.
Neck is narrow because when you compare the sides of the body of the aneurysm, the size of the body is larger than the neck.
Pseudoaneurysm.
So true aneurysm will have all the 3 layers of the muscle which we normally talk about. But pseudoaneurysm,
Correct. So there is a ledge of tissue. This ledge of tissue, the moment you start seeing, that means this is being contained only by the pericardium. So this is a pseudoaneurysm. Now I'll give you the background of this person. Very interesting. He's a post-CABG patient, and post-bypass he came with chest pain, ST elevation. This is what we found, and the surgeon was called, and I'll show you the color picture, and then you'll make diagnosis. So if you look at this, keep your concentration here somewhere. And if you look at this, you'll find that there is a tissue where there is a giving way. This tissue is giving way. Now, it's very interesting. If it is a pseudoaneurysm, all of us are convinced that there's a pseudoaneurysm because there is a ledge of tissue, the neck is narrow, the aneurysm is wide, there is a thrombus sitting there. If it is a pseudoaneurysm, and if there is a rent here, he should have died. Because the pericardium is the only thing which is holding it. So we did a color Doppler, and lo and behold, we did find that there is a leakage. See this. Now, if you have a leakage of this sort, then how is he surviving? So we were totally foxed. But we did call the surgeon, did a quick angiogram, and this surgeon took the patient up for surgery. The moment he opened the chest, this man crashed. He had to put him on immediately into the cardiopulmonary bypass. And you know what was the reason? He was post-bypass patient. And post-bypass patients, these patients, they develop a lot of fibrosis.